Okay, welcome everyone to Research and Discovery Grand Rounds. Today, we're happy for you to join us. My name is Bridget Jones. I'm Associate Professor of Pediatrics at Children's Mercy and University of Missouri, Kansas City School of Medicine. I'm also the co-director of the Translational Workforce Development Core of Frontiers with Dr. Ed Ellerbeck. So I'm happy today to introduce our Grand Rounds today and our Grand Rounds speakers who will talk about community engagement in translational science. But first, we have a few housekeeping things we have to get to. So next slide, please. So here are the conflict of interest statements for our planners and our speakers today. And then I believe just one final housekeeping item just to save the date for our next Research and Discovery Grand Rounds on Thursday, April 28th. Leveraging informatics and translational research will be presented at that Grand Round session. I think that's all of the housekeeping. So next I get to introduce our excellent team here who will be talking about community engaged research. So I have some introductions to do to give everyone a background of on our excellent speakers and our panel today. But first, to let you know, just kind of the spirit and the reason we do Research and Discovery Grand Rounds is to provide information to our community of investigators and staff about frontiers so that you can learn what the things are in frontiers that you might be able to take some benefit from. So learn how to utilize the resources within frontiers, as well as learning how the translational science impacts healthcare delivery and how you can participate in that as a researcher. So first, I'll introduce Dr. Alan Greiner, who is Vice Chair and the Nason Family Endowed Professor of Family Medicine and Community Health at the University of Kansas Medical Center. He's a practicing family physician and serves as the health officer for Kansas City, Kansas Wyandotte County Public Health Department. His public health work expanded significantly, I'm sure, with COVID-19 in 2020 and ongoing. Recently, he has served as co-principal investigator on a large NIH-funded RADx-UP grant intended to advance COVID-19 testing for vulnerable populations across the region. He leads the Community and Collaboration Core and community engagement activities for the University of Kansas Clinical and Translational Science Institute Frontiers. We also have with Dr. Greiner today, Ms. Jarayla Haynes, who is also part of Frontiers administrative team as a community health worker and recruiter. She's been a part of KUMC administration for over 10 years, working in graduate medical education, executive offices, and now has been with us in Frontiers over the past 2 years. Her involvement in community engagement is a natural one, as she's often been an active member of her community since elementary school. So I'm glad to have Ms. Haynes here today. And then last but certainly not least is Ms. Mary Ricketts, who's CEO of Turning Point Training and Development and currently serves as a local Health Equity Action Team advisor for the 20 county communities organizing to promote equity or COPE project for the state of Kansas. She's also serves as a PI support for the 10 county RADx-UP project, community consultant, LHEAT facilitator and moderator for the RADx-UP worksite seminars. And she's also, of course, been very involved in COVID-19 work within the community, particularly with the COVID-CV NEAT, or COVID Neighborhood Action Team Advisors for Casey Mo Health Department Grant Project. And in the community, she serves as the board president for Innovate Her, Inc. and board chair for the Kansas City, Kansas Community College Foundation Board. So with that, you all see that we have an excellent set of speakers. So I will turn it over to the community engagement team.
Thank you, Dr. Jones, and thank you everyone for coming today. We're gonna do something slightly different. We're gonna kind of make this a team effort and talk toward the end about what we're going to be offering with the Frontiers Community Engagement Program to the broader Frontiers community, which I think most of the attendees are part of. But we also want to hit some of the highlights of why community engagement, what is community engagement, why community engagement, and give you a phenomenal example of some current work led by Miss Mary Ricketts, who in many ways it exemplifies what relationship building and community engagement, and then the domino effect of goodness that comes out of this work. And so she'll be talking mostly about the COPE project, which is kind of the biggest project our big team has going that involves community engagement components, but it's really a part of just a piece of some of the things she's doing. So we'll start right in. I'm gonna go over the first about 10 slides and talk about community engagement and its value, some of the strategies we try to use when we're doing community engaged work, address some of the challenges. Then I'll kick it to Mary and we'll talk some about how community engagement has been so important to some of this COVID work. A big group of investigators out of KU Med, KU Lawrence, and KU Med Wichita have been doing, along with a bunch of community partners, including these local health equity action teams, or LHEATs, which I think you'll find is a terrific example. And then Sharayla will go over some of the aims we have and the key features that we have built into Frontiers 3.0, which we are hoping, and fingers crossed, we will get our Notice of Award soon. We'll start officially in July, but some of the features are already ready for you and you can tap into now, and then we'll do some questions and discussion. So next one, Sharayla. And I'm going to go fast. So if you have questions or comments, just throw them in the chat and we'll try to get to them in the end. I want to get to Mary and Sharayla and really have you see some of the examples and some of the things that are available to you. So what is community engagement? I'll talk about that and why it's important. And then I also want to talk a little bit about how we measure it. Historically in Frontiers, we've measured the sort of number of new partnerships we've helped to create by doing matchmaking, the number of services and consultations we've done, or things we call concierge consultation encounters. We've measured the number of community engaged grants that got submitted and that got funded. But going forward, we're really looking for new and different things. And when I talk a little bit about the why of community engagement, I think you'll see that we want to move on to the world of sort of thinking about health equity and how does community engaged research really start to be something that we can measure its impact in getting equity between population groups that have historically not had the same health outcomes. If we can measure that and show that this work has that kind of impact, and we hope we can with some of these COVID grants, which you'll hear about in a minute, that's really what we want to know. We don't want to know how many grants we submitted or how much grant dollars we have. We want to achieve equity with our research work. So next slide, Sharayla. So what is community engagement? The CDC defines community engagement as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. We have seen that interventions that use this kind of with and through partnership are able to improve population and individual health better, and definitely stimulate better knowledge of what it takes to get us to that health improvement and get us to that health equity we're trying to achieve. Next slide. So what are some of the principles that we want to use as we're building partnerships, as we're getting ready to launch into this kind of work? Of course, we want to build these partnerships before we're doing research or we've formulated our hypotheses and research ideas or submitted our grants. We got to do a lot of this relationship building and partnership building way before it's time to submit a grant or it's time to collect data. And from the very beginning, we need to be clear about the purposes and goals of the effort. What are we trying to do? Yes, we're trying to do research, but that's why I mentioned health equity. We got to get that lens at the front of our work so that those partnerships are strong and that people are on the same page. To do that, it requires that research teams, maybe they're not traditionally out there in the community, understanding things like a community's culture, the economic conditions, social networks, power structures, some of the norms that are there, some of the history that's there. But we have to learn about that. And it takes listening, it takes engaging. Sometimes it takes being involved in direct service, like an activity like you see there on the left. That was a big activity from a bunch of years ago, but that Heart to Heart was involved in, and I know Juntos was involved in, and some of us in Family Med were involved in. That's how you learn these things that are so important and develop the partnership, right? We talk about requiring partnership development. That's got to be based on mutual respect and a commitment to addressing health issues, not just doing research, but working to address those local health issues that are of importance to the community members, maybe not so much to us as researchers, but to those community members. We got to recognize the knowledge and skills of the organizations and individuals that we're working with out there. Sorry, Shirley, next one. So why do we want to do this? We want to assure that study findings will be more likely to achieve the improved health outcomes when those study findings are utilized in real world settings. So if you think about something like a new medication or a new device that's developed for health improvement, sometimes those things are not so good in real world settings as they were in randomized controlled trial settings, where we've got all these exclusionary criteria on who we recruit and allow into the trials. The same is true for all sorts of public health interventions and all sorts of health services delivery models that we may be tweaking with research findings. If we do this right and we have community engagement as we're doing the research, we believe that we can put those things in the real world and they will have impact much more quickly, and they will be much more likely to have that impact. We will essentially be pre-addressing the kinds of challenges you face when you're trying to put something out there into an environment where it can have an impact. Again, whether that's a new drug, a new device, some sort of health intervention, some sort of change that you're making to the way you deliver healthcare. All those things you're doing pre-addressing work when you do community engagement. And we want to advance health equity. You're integrating and valuing the input of community members, and that's going to get you to that ability to do things that we traditionally haven't always worried so much about, but really get those differences among different populations to level out, which is really the goal we want to see happen. Down below, there's Trish Long from the Masonic Cancer Institute. Some of you may know Trish. She's trained a bunch of promotoras or community health workers out in Western Kansas over the years, and that's a group that's done some great work out there. Next slide. There is something we call a continuum of engagement. So engagement can be at different levels, right? And if you're new to this, as you get into it, you may find that you're working sort of over here more on the left-hand side with things like outreach, where you're providing information and services, or you're doing consultation with a new community partner. But when you start to invite the community members really to the table with you, that's when you get to the middle of this and get to those levels where we really think we can start to see equity affected. You start inviting community members, you start showing that you value their knowledge, their skill sets, their ability to be part of your research team, and you got to fund them as part of your research team. If you get to these last couple dots on here, and you're forming partnerships from the development of the original study idea all the way through completion and data analysis and dissemination of your findings in things like publications or presentations you're doing. If you've got shared leadership, and that's something that we've been trying to build into recent projects, where we literally have PIs, principal investigators, that are community members, or people like Miss Mary Ricketts, who literally is running a huge part of some of our grants. You really have something that's different and unique, and I think can bring value when it's crucial. We found that to really be the case with COVID, and I think it's definitely the case with so many other research areas that we work in. Next slide. So what are some of the challenges? This work is not easy. It takes a lot of time. It takes time investment. It takes the ability to create things that can sustain themselves. You got to overcome this trust, a history of poor communication. Definitely in the health sciences and the biomedical sciences world and in the research world, there are issues of historical respect that I do not think we've always recognized and apologized for and tried to make amends around. These are the kind of challenges that sometimes you face when you go out there to start building relationships. But again, the end goal is really important, and so it's worth the time. But we got to do things to support that. And again, that's what Frontiers is trying to do. There are differences between the way academic folks and researchers see the world and community members and leaders of community organizations see the world. We have different objectives sometimes, but we have to find that common ground. On the left, we talk about some of the things researchers may bring to the table in terms of not having great history of relationships or having that time and willingness to deeply understand communities. Sometimes our funding doesn't suit this model very well. And sometimes we don't have that proper perspective of trying to bring tangible benefits to the community. On the community side, it may be other historical issues. There's definitely, a history of, instead of talking about community and individuals or study participants as participants, they've been called subjects historically, and that kind of thing is important to acknowledge and try to overcome. And then we've got to compensate people for their time and help them get experience in the research world and get that knowledge so that we can do this work. Next one. So we've talked about different things about this. I just want to give you some examples of some of the medical center entities that do this kind of work on a regular basis. Most of these are medical center entities. The HARC, the Health Humanities and Arts and Research Collaborative, is a KU Lawrence entity. But these are some of the programs that are constantly doing community engagement work, and some of it's research. Sometimes it's just around that relationship and partnership building. And Frontiers is connected into all of these and more. And so if you've got projects that can potentially fit some of these things, we want to be helpful to get you connected in and utilizing those kind of resources. We'll have future sessions where we'll talk about some of these, like Pivot or the Masonic Cancer Alliance, or FaithWorks or K-Pepper. But I just want to show some of the examples here of entities that are out there and engaged all the time. Next slide. And I think this might be my last one. I mentioned the sort of longitudinal approach to this, that it's extremely important to try to sustain engagement and not think about these kinds of things as grant to grant relationships. So we need some of the programs like the previous slide that have sustained, in some cases, sustained relationships for 10, 15, 20 years. That requires a lot of respect. That requires meeting each other's needs, whether they're research needs or other needs. That requires that deep awareness that I talked about. And it really requires a long-term commitment. And so a lot of those programs that I mentioned on the previous slide, they have that long-term commitment. Frontiers is working to help support that too. And so over time, we hope Frontiers has some of that as well. And so we want to have these things be long-term, not grant to grant. And it's our job to help you all do that and these programs to keep going and do that. So I think I am finished with my next slide. So I'm going to turn it over to Mary Ricketts. I want you all to know that some of these COVID projects that we mentioned, RADx up at the beginning, and then this COPE project, which is a current one that Mary is deeply involved in and helping lead a big component of, they really come out of a model of, to address COVID, we need community input and community voices at the table telling those who are responding to COVID how to do some of that work. So it's very similar to this idea of, in research, we need community voices advising us how to do better projects. This is all about the community doing that. And so, Mary, I'll stop babbling and turn it over to you and let you run with this next portion. Thank you so much.
Thank you, Dr. Grider. And that was a good segue in. Good job, everyone. One of the things that that is really, really important when we talk about Project COPE is it took us past just talking about COVID and COVID-19 and vaccinations and testings, which is a lot of what our RADx Up project was. So when we have the opportunity to assist and be a part of this project, it was really, really huge. It was really important. We have a phenomenal team that is working on this. I have to give a shout out to my other LHEAD advisors, Dr. Vicky Colley Akers, as well as Christina Pacheco. And we work on this piece of the project together. And it is exactly what it says, communities organizing to promote equity. We can't do it well without the community members being involved. Next slide, Sharayla. In the COPE project, it is large. It's large for us, let me put it that way. It is 20 counties. It is 20 counties across the state of Kansas with us. We have maybe 6 of our counties that were part of our RADx Up project. And so we're transitioning them at the same time to be a part of COPE. It is truly aimed at addressing the social determinants of health and health equity for underserved populations that were exacerbated by the COVID-19 pandemic. And I know we're not saying anything new, but when we saw a lot of the projects hit, even at the beginning of the pandemic, that some of my team and I got to work on that involved community, it was like, oh my goodness, community needs to be at the table. Community has a voice. And so many of our community members know exactly what's needed, not just for their county, but some of them can get down to the neighborhood because they know exactly what's happening where. They know the community members. They have that, we talk about feet on the street. They have the ear. They have the ear of what's going on in the community. And real quick, this particular project with COPE is a partnership with KU Medical Center, KDHE, and it is being funded by the CDC. Next one, Sharayla. This gives you a good idea of the scope of the project that we have. We did have to break it down into 4 counties, 4 regions, because we have 20 counties. We have our Southeast region here. We have our Northeast. We have our Central, that's a little bit more spread out. And then we have our Western region. So we have a nice diverse group of counties. Each one has an LHEAD lead. So we have a person that leads the local health equity action teams in each one. And I'm going to break that down a little bit for you and let you understand what the roles and responsibilities are from those that lead it, as well as who the members are that are coming to the table. Some of our county in this project are also part of RADx Up. You'll see those with the stars. And then those with the K are also part of the clinical KHC project as well. Next slide, Sharayla. This is probably the meat of what we really want to share when we look at helping all of our counties create the local health equity action teams. First of all, there were a lot of lessons that all of our team members learned from our RADx project. It's like, okay, we have this opportunity to make it larger, to expand it past just talking about COVID. What do we need to do differently? How do we make sure that we do a better job or expand the work that we did with RADx Up into COPE? And when the team and I really started talking about what does an LHEAD need to look like, how do we bring the most value to every single county based on what every county has a need of. So what we need in Sedgwick County could be completely different than what the needs are in Bourbon County. And who needs to be at the table may be a little bit different. So one of the first things we did was really take some time, and we still adjust it as needed, is really define who do the LHEAD members need to be? Who are they? And this is what we have put together. It's a team that creates and implements strategies to address health inequities in the counties who are underserved. We were very strategic about the wording on this. Just to be very clear, because we just don't want you to come up with the strategies. We want you to help implement them as well. This is where everyone's hands get to go to work. All right. Not just put together the strategy and pass it on to someone else, but how do we all together come together as a team, come up with the strategies, as well as implement them based on the needs of what their county has. It has been amazing working across the 20 counties. It has been amazing to connect with people in the 20 counties, the diversity of the counties. Everyone looks so different and the needs are different. We definitely wanted to make sure that it was members that live in the county. You don't need Mary Rickens coming from, I'm physically in Overland Park today, coming to Bourbon County to tell you what you need to do to make this work. You know, and if we give you the right tools, we can help you and guide you along the way. But we definitely wanted members that live in the county and reflect the diversity of the communities in the county. Absolutely, we're looking at race and ethnicity. We're looking at gender. We're looking at sexual diversity, religion. This is one that I think we miss sometimes, that we're trying to do a much better job, but age. Age also is included now. And we get so excited when we hear that one of our LHEATs maybe has a college student or a high school student that is involved in what needs to happen. What they're there, they're part of the community. Why not make sure we hear what their voices are? They see things with a much different perspective as all the others do. And when we talk about education as well as income, the other thing that was really important was doing our best to make sure that we have trusted community leaders at the table. We're not talking about political status. We're talking about community leaders. The community leader could be the person that's running the food pantry at the local faith-based community. The community leader could be the person that is working on something to serve whomever. It could be someone that's running a singles ministry. It could be anything, but that's the community leader whose voice we need to have at the table. The other one that we're looking for those people who could provide links to local networks and organizations. I'm sure most of us here have heard of community health workers. What do you say, Sharayla? I didn't know who community health workers were and how important their role and responsibilities were, probably until about 3 or 4 years ago, dealing with Broderick Crawford. And he's like, what do you mean you don't know? I'm like, I'm not connected to that portion of the community that may have need. It's things like that that are so very, very important. We have to have people that are connected to local networks and organizations. Who has the resources? Bourbon County knows who has the resources. Crawford County knows who has theirs. Thomas Sherman knows who has theirs. This is why having the right people and a diverse group of people, not just organizations, but community voices that have lived experiences also need to be at the table. The other piece that was still important to us on the project, even though there isn't a huge COVID project, we still need to make sure everybody has a good understanding about the importance of still getting tested and still getting vaccinated. Okay, here's what we've asked them to do. Continue to collaborate to identify the specific needs of a specific community. I will give you an example. One of our Western rural communities that we connected with on a fabulous road trip, Sister Janice is her name. But I will never forget in one of our meetings that everyone's talking about where they're going to, all the activities that are going on. It was Sister Janice's voice. And I know how old I am, so I know Sister Janice is older than me. But she's a senior lady, but she is very, very well connected in her community. And out of her mouth came, yes, but we have a particular trailer park in our community that we've had many outbreaks in. They have needs. And guess what? Transportation is an issue for them. This is when we know that even from the research side, it goes past those SVI and ADI reports. It has to go past that. It has to go to that next step and getting the voices of the community to the table. The other piece that was really important were the rapid assessments that we're doing in each of the 20 counties. And that's where we really bring the community voices in, those community members, to help identify what are the needs and the barriers. If we think about my own county, which is Wyandotte County, and I tell people this all the time, I live in Wyandotte County. I actually don't pay attention to how large our county is. Hint, the research piece is huge because on the report, we can see where the pockets are, but the community voice saying, yes, Mary, but don't forget, that also includes Bonner Springs. It also includes Edwardsville. I'm like, I've lived here all my life. That doesn't ring a bell to me. Okay, we have to fix something. Community voice and research. That's why we have to partner together so well. The last piece that we did was really work with each of our counties, and each LHEAT group comes up with their own 30-day action plan to get an understanding of what they want to do. Who do you want to impact? The reports will show us, right? The research will show us who's where, but then the community members that also have those voices and hear what's going on can let us know who's really struggling the words. What are you hearing? What are you hearing and what are you seeing? What's the conversation at the grocery store or the beauty shop or the barber shop? What's the conversation at work? What are you overhearing when you go to your fast food restaurant? Those are the things that are still important. Sharayla? Here's why. This ties in right along with what Dr. Greiner had already talked about, community engagement. And this is what our LHEAT advisor team, that we call our LHEAT Angels, this is what we came up with. Community engagement is based on the democratic idea that everyone who is affected by an issue that impacts their community should have a say in the decision-making around it. Hint, age has surfaced. We want to make sure we hear from our young adults. We want to make sure that we hear from our teenagers as well. If we miss it, shame on us. If we have access to them, we've got to make sure that we bring their voices to the table as well. Sharayla. Here's the beauty. Here's the beauty of what our desired outcome is within our COPE project, within working with the local health equity action teams. And this is really important. We are talking about when we do this, we want to help build relationships between healthcare and community. Imagine that. Build those relationships between healthcare and community. And that's all forms of healthcare. Doesn't matter if it's our health department, our coalitions, our FQHCs, who is serving our community members that we are very concerned about, that we know we have some past concerns with, and COVID has just really, put that magnifying glass on some of them for us as well. The other piece we want to do is, by doing this, is really help build trust within the community. So when they see an announcement come out, when they hear that radio announcement, when they see the TV ad, and you're talking about diabetes, or you're talking about dental health care, you're talking about mental health care, that we've got relationships built. So when we see it, we're like, oh, okay, yeah, I can trust them. There's an old saying that talks about people need to know how much you care before they care about how much you know. And that's true. The other piece we're hoping to address by this is really reduce hesitancy. Reduce hesitancy, not just about getting vaccinated and getting tested, but reduce their hesitancy about reaching out. Reduce hesitancy about communicating about where your struggle is, what your need is. How do we help you, your family, your neighbor? What do we need to do? But we can't do it if we don't know. And it goes past just seeing it on a report. It's not just the white paper that we need to look at. It's not just the detailed report. The SVR, the ADI report comes back. We need to hear from them so that we can absolutely help reduce the hesitancy. The other piece on that side is provide specific services based on specific community needs. If the community says, we don't need another food pantry, we don't need another food pantry. If another community says in one of our other, in Harvey County says, oh no, we don't have enough food pantries. We need to find out how to make that happen. Do we need mobile food? Is food scarcity the concern, not just in a county, but is it a specific pocket within the county? This is why community ears, community voices are needed along with our healthcare and our researchers. The end result that we hope for is that we do help improve the health within all of our counties, help prevent disease, reduce disparities, and then create conditions for equity. And that's huge. Creating the conditions for equity really means that we have to have community member lived experience voices at the table, not from the after effect, but at the table at the beginning. Bring me in when it's time for the salad, not just for the dessert. I think I like that analogy. Bring me in at the appetizers. Oh, I missed one. Bring me in at the appetizers. Let me order my own. Let me order my own appetizer. Don't assume that I like the same thing that you like. If Dr. Grider and I are like, we are all about our raw oysters, and Sharayla says, no, I prefer something else, it doesn't do me a bit of good if I ordered, 5 dozen of raw oysters. Sharayla's like, thank you, but I don't eat that. That's why this is important. This is why it is so important to keep every voice at the table and that your voices are diverse. Sharayla, next slide. One more, hit one more, and I think let's talk about the community stakeholders. Lessons learned from our previous project, and our previous project is excellent, please don't hear me wrong, but we found that we had a few gaps that we wanted to make sure that we helped with the COPE project, and it was community stakeholders. Community stakeholders, those are the members that provide the lived experiences. You've heard me bring that up many times. The lived experience, who has the actual unmet needs, and they have them, you all. They have the ideas about how to improve access. They can tell you, no, this doesn't work because the bus stop is 8 blocks away from where this particular community is. That's not going to work. So how else do we help with their unmet needs? What are they? Okay. Next one, our community health workers. We so appreciate the fact that we learned we need to add some more help to the table for the LHEAPs. So for every one of our counties, we can have up to 3 community health workers that are also a partner in the LHEAP. Everyone's voice is needed at the table. Those are the members that are actually helping implement the actions and the activities that the LHEAP comes up with. So those 30-day projects. The community health workers are also those that engage the community by identifying the collaboration that's needed between the LHEAP and the services. Here's what that would look like. We have community health workers in Thomas Sherman. They're the ones that are with the community members that have unmet needs. Guess what? They'll be able to invite them to an LHEAP meeting and say, hey, would you mind sharing what's going on with you or your story without telling too much to our local health equity action team, because we value your voice. It's nothing like hearing it firsthand. But if we have to have our community workers share, hey, I'm working with 20 clients and I know that I've got 10 of them that are struggling with this, and this. Great. Here's our team. And we have another important part of the team that will help put it together. And those are our organizational leads. These are members that know the services, and these are our partners that are within the region, that are within the county. And they're also the ones that know about the existing events, the existing activities. If we're working with, I'm gonna bring up Juntos. If we're working with Juntos and Juntos says, hey, I know that we need to help, and how can we help? If we have organizations that are also serving our communities or have a huge desire to start serving the communities that have the unmet needs, it helps build the trust even faster. Because if you're already a faith-based community and you have a food pantry and everybody knows your name when you walk in, you know how good that feels. And they're saying, Here's what we're hearing, and I can invite a couple of them to the table so they can share their lived experience. That is so important as we complete this. I have one more slide I'm going to share with you all. And then Sharayla, I believe I get to turn it back over to you. Here's what we asked back from each of the LHEAP members. Every one of them, our community health workers, our stakeholders, and our organizations that come to the table. And let me preface it with this. We've also learned we don't want to be so organization heavy and not lived experience voice heavy. Okay. We don't want it to be 12 organizations and 2 community members there with lived experience. And it's not saying that I may work at the community health center, but I may also have some unmet needs and I'm still a member of the community. We understand that we have lenses, different lenses and different perspectives and lived experience within the organization, but we know that there's a difference if an organization is coming and that's their job, duties, and responsibilities versus we need to make sure we have a good number of community members and stakeholders at the table. So I wanted to add that in there. Here's what we ask from all of our members. Attend the meetings and provide input and feedback. We want you to show up and we want you to have input and feedback. And we've also had our LHEADs that many of them, their meeting times, you all, is 6 o'clock. It's 7. Matter of fact, I have one tonight. I get to attend. It's at 7 o'clock tonight. Guess what? Because it's a sacrifice. It is time consuming and it is a sacrifice. And we get that. So if we're going to get them together, we want to make sure that it's valuable for everyone that attends. We want to make sure that it's a safe place for everyone to raise up concerns from their communities. One of our LHEADs that we've worked with, and that's actually crossing over with both the Radix up in the Cope, mentioned one time, they are still struggling with bringing members of the community from both refugee and the Asian community to the table. Guess what? We're here to help. What do we need to do? Do we reach out to another organization? Do we get a hold of the National Asian Chamber? What do we do? We don't know, but we'll come together and we'll brainstorm and trying to help figure it out. We want to make sure that they demonstrate commitment to developing an understanding of issues, watch this, that they may have little experience. I might be a community member at the table. I may have unmet needs, but I've never been homeless. So I need to make sure that if we're working on the project that's dealing with and supporting our unhoused community, I need to be okay doing my own research. I need to be okay listening and understanding this need and this perspective is different than something I have doesn't make it unimportant. It is important, okay? The next 3 I'll run through real quick. We want to make sure everyone suggests strategies to address the health inequities, okay? Brainstorm, bring in strategies. We have one person that leads each meeting. We have an LHEAD lead. So we have someone that helps facilitate those discussions so that everyone's voice is heard, that every perspective is respected, right? And that together as a team, all 3 of those will come together as a team and come up with some opportunities to impact the community. Advising the development and implementation of events, activities, and communication strategies. Communication strategies is also another big one because we want to make sure that we're providing communication in the languages that we need to. Okay, this is when sometimes we have to remind ourselves everything is not English and Spanish. Some of our counties have other languages that they have need of. We have to know about that and we have to work diligently to provide it. And lastly, most importantly, we have to have those that will provide their real life experiences, be honest about what they're going through, know that it's a safe place, and know that this team is here to help. If you have any questions, please feel free to put them in the chat for me regarding our LHEAD. If I need to bring in the rest of the LHEAD crew to help answer questions, let me know and we'll be glad to help and support any way we can. Sharayla, I will turn it back over to you.
Mary, thank you so much. I really appreciate you being here today because I know how busy you are, and for you to lend your insight to the people that need it, it's not unnoticed, and we really appreciate you. So my name is Sharayla Haynes, as said before, and I'm going to try to go through these slides quickly so that we have enough time for questions. I know there's some in the chat that have been addressed, but in case there are more, forgive me if I go through them quickly, but these slides and this recording will be available later so you can go back through them. So as on the administrative staff here at Frontiers, we have to figure out, how does this tie into what the NIH actually wants? So what did we say in our grants? What did we say in our renewal that will tie in and will make sure that we are actually supporting and doing what the NIH wants? So aim one, you all can read this for yourself. I'm just going to hit some of the hot points, but we need to train the investigators to work. So it's just like when Alan said at the beginning, it opens the door for you to have this conversation, but to be trained to work with these communities and all the stages is how we're going to continue to bridge that gap, because it's not just about, if you are a researcher and your goal is to make the community better, your first step is to have that engagement, not just to recruit people. I'm just trying to recruit as many people so I can make their life better. We're recruiting people to have a conversation and have a dialogue and have a relationship. So the second aim would be to build and deploy that leadership and the health worker team so that it can be a team. It can be a dialogue. It's not just the researcher on the hospital hill talking down to the community and saying what they need. It's a conversation, it's a team. And then the third aim would be to ensure that bidirectional communication continues with the stakeholders, and that communication is not just one way and saying, this is what I need, and then that is it. That is not the aim. That is not what we submitted. That is not what the NIH wants from us. We then have to go back to that same community and say, these are the results of the study that we did. How do you feel about those results? How does that impact you and your community? How can we do better to communicate that information? Is there a group we forgot? Is there something that we didn't do? What can we do to make it better? Those are the priorities here. So I'm just going to go through some of the newer components that we submitted in our renewal for 3.0, including our leadership team, which has community advocates, which shapes and oversees all the community engagement programming. We interface with researcher staff and community advocates. One of our newer groups is we call it the MARG, because we in research love acronyms, do we not? The Multidisciplinary Advocates and Researchers Group. It is composed of researchers, community advocates, and guest presenters. It's supported by HARC, which Alan mentioned earlier, and we meet monthly, and our steering committee meets bi-monthly, which I'll go over that leadership team on the next couple slides. And our partnership support team, which is staff and community health workers. So most of you know these people, but this is our leadership team. These are the voices that reach the other voices that reach the other voices that we listen to and that tell us, I think you need to take a step back. We need to try that a different way. So Andrea Bradley Ewing of Children's Mercy, Roger Crawford of NBC Community Development Corporation, Tamara Falikov of KU, Kim Hewitt of KUMC, Dr. Jennifer McKinney, Mongsana, Jamila Watson-Thompson, Mariana Ramirez-Matilla. And so just going into a little bit more information about the first aim, which is to train. So we're doing the quality by design. We're doing these nano experiences. And I'm sorry I'm rushing through this, but I want to make sure we have time for questions. Like Mary mentioned, if you have questions about any of these, my email address, I'm Sharayla Haynes at KUMC, or you can put it in the chat, but I'm just going to go through these again. So we have a storytelling component that I'm really excited about. We have someone coming in a couple of weeks where we are going to be training the trainers. So this small group will then go out and train more researchers. I will go out and train more people, and I'm so excited about that. And we want to make sure that we have a small annual conference for community engagement specifically. And also we have a community co-investigator human subject certification training, which should replace what we take as city training so that we can really get the community involved in the research in a way that engages them, not just as participants, but as real stakeholders, like not just in name, not, oh, these are our stakeholders, but these are people that actually know what research is the same way that we know what research is and can actually do it and then share it and continue to go back and make that bidirectional. So aim number 2, build and deploy this leadership community health worker team so that we can do engagement communities. And that's where I come in. My job, as I see it, is to bridge the gap between all these multitudinous communities, all these different groups, and bring it back to Frontier so that when you as a researcher say, I want to do research on XYZ, but I really don't know a lot of people in that community other than maybe the people I serve in my clinic or something like that. We connect you to the right group. And that's why we have these concierge services and we have a partnership support team. And that's why we attend all these, the meetings, and we go to the events, and we try to create that environment so that we can keep our ear to the street as well and find out who's doing what, where, how can we connect, how can we support? And then if something comes up where we need something from them, the conversation has already started, the relationship is already there, the trust is already there. That's what we need. And for our third aim, and this is our final slide, ensuring that optimal bidirectional communication between the stakeholders with emphasis on how study questions originate, study design decisions are made and implemented, and communication of results. I can go into detail about what that means later on. Maybe we do definitely need to come back. I'm just going to say that now, Ashley. We just need to come back and we need to have another grand round so we can go into further detail. But our Frontiers communication standards for communities and community partners, we want to develop the standards that are necessary and appropriate. And we can't do that with our own minds. We have to reach out to the community. It's just like Mary mentioned, it's not just English and Spanish. And a lot of times we forget that. It's not just people that are working adults. That's the biggest one, Mary. It really is, because we live in a world where kids have access to the internet. They have access to NPR. They have access to all the same types of information that we have. And for us to have those communication standards, we have to reach out to them. And to implement the standards through these tools. So we definitely want to build and disseminate these tools. I think Alan knows this is one of my passion projects, once we get our website up and going, is to make sure that we have a toolkit for researchers so that it's not just relying on you emailing me specifically. I'm going to email Sharayla. Oh, you know what? Let me go to the website and use the toolkit, because everything is there that we need in order to implement these strategies and these standards. That's my last slide. Thank you all for your attention. I'm going to stop sharing my screen now, turn it back over to Dr. Jones. And if there's any questions, feel free. Thank you.
Thank you all. That was just really, really excellent. Lots of great information and just a great discussion and exciting information. So we do have a few questions, or at least I saw one question in the chat. If I can go back up here. I think there was a question earlier about for Dr. Greiner or the group in general regarding tangible benefits. So you mentioned that, when community members engage in research, we want to make sure they actually benefit from that in some way. So how is it determined whether there's a benefit or not for the community?
Yeah, and I threw in a little bit of text there. Hopefully my colleagues kind of agree with me. I think that, that question is really for our community member partners. And I hope we've got the relationships with them in such a way that they feel empowered to, to say what's going to benefit them and their community, and to realize that as their partner, we're going to find a way to be yes people and not no people. That has always been kind of my philosophy with this work. And I think that's what builds the trust and gets over the historical issues that we've had of having that trust. But I'd be curious to hear what Mary and Sharayla think too on that one.
I got something. Let me tell you how I would answer that. You have to ask the community. What good is us for, why do you want us here? Why would you allow us to come in from a research standpoint? What do you want out of it? Because what Mary wants and Alan wants and Dr. Jones wants, it's all going to be different. Sometimes we may just have to ask, how could this benefit you? Why would you, it's so different. Why do you want us here? Why did you open the door and allow us to come in? What do you really want to see? And how does this look like success for you and your community or your neighborhood?
I'll just piggyback and I'll just say, when you have a relationship with someone, you don't usually try to coerce them into things. My children being, I do coerce my children and I do have a relationship with them. But when you have a relationship with a group of people that it's hard not to care about someone you have a relationship with, period. So it's not coercion at that point. It's really seeing a need in the community and filling it, period. Hard stop.
Great, thank you. Okay, and then someone asked, can you elaborate a little bit more on rapid assessment?
Yes. This is funny, haha. So in our previous project, it was a long assessment. It was, I mean, it really was, it was huge. So what we did was reduce it a little bit and really made it more of a conversation piece where we share the SBI and ADI reports for each county. And we Dr. Vicky Colley Akers helped put together this fabulous presentation that we walk each county through, but it's really more of, here's what we see. What do you see? And who's there? And if we had to put it on a map, what does it look like on a map? What's been done? And it really is taking an assessment, but also an inventory of who's already serving in these communities, where's the most help need. And it's more of a conversation piece than it is, we've got, an 80 question survey that we need everyone to check off. So we changed it. That's why we call it the rapid assessment and not the initial one. So that it's simple, it's smooth, and it's a conversation, and it's less intimidating, especially for community members to have a conversation about it. I hope that helps.
Yes. Anyone else want to add anything else? I think Mary probably covered it. Thank you. So I don't see more questions in the chat, but I have a question. So if I'm a new or early researcher and I have something in my head that I think would be a great community engaged research project, where do I start and where do I come to, especially within Frontiers? How do I get started?
You can email me. You can actually email anyone on the Frontiers team. If you go to our website, I'll put it in the chat. There are leads to different areas of our renewal of or our grant. So it might be something that, well, Sharayla might not know, but you can definitely start with me and I'll connect you to the right person. Or if you're on the website and you see, oh, I definitely want community engagement, let me reach out to Dr. Griner directly. Reach out to him, CC me. Or yeah, CC me, it can't hurt. Or it might be, implementation science that you have a question about. That's on the website as well. You can contact those people directly. They are on the website and they know they will be contacted. They are, I would say, maybe 1 to 2 day turnaround for that, or pick up the phone and call us if you need something more urgent or emergent. And now if you're in the KUMC system, you can use Teams. Teams to contact someone now just via chat. Sometimes we're in meetings like this one and you can just kind of reach over and answer someone's question and say, email me that and we'll get back to you. Alan, I'm sure you have more to say.
Well, and I think Sharayla is one of her sort of title's community health worker and recruitment lead, but she's a navigator, right? And I think we've got this model in front. I don't want to speak for Dr. Leader, he's on here, but we've got all these navigators and any of them can refer to each other too. So if somebody, I know I was emailing on some things with Dr. Leader this morning where somebody came in from a side angle on Frontiers with kind of a community question, and then it went from there to other people. So I think all of us, Dr. Jones, you and I are on the leadership team, but we've got all these navigators. I think we're all a web, and that web, whenever there's a touch, we're gonna pass it through that web and get people going on things. And for us, it'll be getting that junior person connected to a community or entities that we think can be helpful to them and can shape what they're doing.
Thank you. Yeah, Steve said he's going to contact Sharayla. I think we all will. Okay, so I think we're at 1 o'clock. Thank you all so much for the wonderful presentations today. It was very, very helpful. Everyone, please make sure to claim your credits. And also, I believe it was put in the chat that this presentation can be accessed via the web posting as well. So if you want to refer back to any information, you can do that. So thank you, everyone. Have a great day. Bye.
Thank you.
Thanks, everyone.